At the end of the day, that's really what we're about at ONC is saying, how do we create that kind of open environment that allows for, sort of a vibrant ecosystem for innovation that serves patients, at the end, ultimately serves patients. I mean, obviously you've got to get providers, who adopt the technology, because if they're not adopting the technology, the patients won't benefit from the technology. You got to get health insurers, you have to have others, but if it's not about the patient and serving the patient at the end of the day, then we haven't done our jobs right.
All right, here at the MedHealth Summit here in Detroit, and I'm extremely excited to bring in Dr. Micky Tripathi for this interview. We're doing this in partnership with MedHealth Summit, Into Being, Wobot Health, and our Meeting of the Minds podcast. But the goal is always the same, is to explore that intersection between healthcare strategy, technology, health equity, and learn from leaders who are actually out here doing the work. So it's an honor and a pleasure to bring in Dr. Micky Tripathi, who is our National Coordinator for Health IT at the Department of Health and Human Services. Before we get into it, though, some of the things that we want to focus on today, like we hear a lot, of course, about artificial intelligence, but you've heard from me, you've heard from other guests, that there's an important foundation that needs to be built, an important foundation of solid, trusted, ethically sourced data that we need to even be able to build towards that future. So really happy to get into it with Dr. Tripathi about some of the work that they're doing at a national scale to enable these kinds of things to happen.
Great. Well, thanks. Really delighted to be here, and you got to call me Micky.
Micky. So, okay. All right, so
part of the ground rules here.
Let's reduce the number of syllables.
Right.
I expended my syllable count by going with the job title itself.
It was painful feeling you tortured path to get there. Yeah.
Well, let's go into that tortured path, honestly, because I was looking at your background.
It does describe my career. Yeah, a very tortured path. Yeah.
I was looking into it, and I saw that there is there's a deep understanding of the social sciences and the quantitative sciences, and I'm always interested in how all these things converge into the type of work that you're focused on today. So would you be okay talking about, we'll get into the the technology platforms you're enabling, but I'm really curious about what's brought you here.
Yeah. Well, thanks for the question, and really appreciate being here. So I guess I've always been really interested in, sort of where technology and policy and basic human behavior kind of come together. This is more, that wasn't a plan from the beginning. It's more as I look back and sort of think, what is the thread that's connected a lot of the different things I've worked in? And I think it's, really that. I started off when I was in college. I mean, both my parents are physicians, immigrant parents, so there was you're going to be a doctor too, right? And so, so I went to college assuming that I was pre-med, and I was pre-med all 4 years, and was always like a big math and science guy. But increasingly, as I got to my senior year, I sort of realized that, I really was much more interested in, sort of things that you could do that would influence at a higher level, rather than working, sort of at more like a one-by-one individual level, like a physician may, for example. Now, this is, back in the 1970s, 1980s, so the opportunities have expanded a lot for, physicians, and physicians are working in tech environments and for startups, for McKinsey and Boston Consulting Group, and and just practicing medicine. Back when I was sort of growing up, they were more channeled kind of sort of approaches. So anyway, I was always very interested in that interface, but that's when I decided I really wasn't sort of going to go into computer programming or go into medicine per se, just because I wanted to work more on sort of policy, political science, economics, more at the policy level. So that got me involved in, went to Washington, got a degree in public policy, then worked in the Defense Department for a number of years. And that's where I really decided or felt like, all right, I've made the right choice here, because it was I was sort of working in an office that was right at that direct interface between high technology, which is was in the defense industry and weapon systems, but technology and thinking about policy thinking about economics and how all those things together, how all those things come together, and sort of being at the forefront of science, and then thinking about the policy dimensions of it, and then how do you actually turn that into policy that becomes things that affect people's lives. So often you have, well, here's the right answer from a scientific perspective, but it's like, well, there's a big gap between that and what ends up turning into policy, because a lot of things happen along the way. So I got very fascinated with that, and then I got into consulting, and that's where I got very involved in health information technology in particular, and that's what led me to leave consulting and decide that I was going to focus sort of the latter part of my career on health IT in particular, which I've been doing for the last 20 years.
Well, that's tremendous, and I really thank you for sharing that story, because I could have a whole bunch of questions on like recent policy and technology changes and things like that, but there was something really powerful that happened during your keynote presentation, which was the opening story was with regards to someone who had the wrong kidney removed, but it potentially could have been avoided had the right information been there for the clinical team working on that patient. And it leads me to a bigger question, just knowing that you've seen from so many different angles. What's the vision? How are you, as far as the type of policy landscape that you're looking for and the types of actions that you're hoping for from our audience of people who are on the digital side at payers and the healthcare systems and things like that? What is kind of a guiding truth that they should be looking for from you and looking into in their own organizations?
Sure. At the end of the day, we want technology to serve people. And too often, I think, particularly in, highly complex areas like medicine, for example, people, both patients and providers, feel like they're a slave to the technology, that they're working for the technology rather than the technology working for them. So a lot of what we try to do is, sort of focus on how do we get systems that have the innovative energy of the marketplace. So we're not talking about the federal government creating an electronic health record for everyone, right? Which some people have sort of said, well, why aren't you doing that? And the reason I usually have is because you would hate me if I did something like that, because the federal government is not good at designing software, is not good at these kinds of things that have to be very agile, have to be sort of very nuanced in terms of being things that people can integrate into their day-to-day lives and have it be seen as something that helps them to expand their horizons and expand their possibilities, whether you're a provider or a patient or or others. So we've very much taken an approach of saying we want to motivate the use of these technologies. We want to make sure that they're based on open industry standards, so that you don't have baking in or vendor lock-in with particular technologies, and so that it's an open architecture kind of ecosystem, because you want it to be a platform for innovation. Here at MedHealth, there are a lot of small innovators. What we want to be able to do is say, we're focusing on creating that open architecture environment, that ecosystem, for you to be able to grow and have your innovative product, be able to market it, be able to have the assurance that it'll be integrated with electronic health record systems, with other kinds of systems, so that you can build B2C innovation, or a B2B, or a B2C2B, or a B2B2B, or whatever it is. We want to be able to create that kind of ecosystem so that you're able to do that. So at the end of the day, that's really what we're about at ONC, is saying, how do we create that kind of open environment that allows for sort of a vibrant ecosystem for innovation, that serves patients, at the end ultimately serves patients. I mean, obviously you've got to get providers who adopt the technology, because if they're not adopting the technology, the patients won't benefit from the technology. You got to get health insurers, you have to have others, but if it's not about the patient and serving the patient at the end of the day, then we haven't done our jobs right. Well,
I got to say, there's another interview that we just did with Dr. Mohammed Ghassemi, who heads the Human Augmentation and Artificial Intelligence Lab at Michigan State University. And we ask everybody, if you could change one thing about healthcare, what would it be? And his immediate answer was that he wanted all these different data sources, all these different things to come together and synchronize, because the type of work and the type of algorithmic exploration that you, when you have trusted data all in one place, becomes huge. So I wonder, so given what you've laid out, And given that type of vision, I know that there's a lot of people out here watching that have that same interest, but have also run into the pain of like the incentive structures around how do we break down those political and technological barriers to get there. What are your thoughts on that, or what are some of the things that you're focused on in terms of like how to create the right incentives around sharing data?
Yeah, it's a great question because just thinking back on sort of his vision of being able to have all that data, well, unless the incentive structure is right, which I think you're appropriately pointing to, that doesn't easily happen, or it doesn't happen at all, right? I mean, data is always, excuse me, data is kind of a byproduct of a process, and you're not going to generate data for someone else's benefit, right? I mean, at the end of the day, every one of us is working on what we're working on. We generate data either as a byproduct of that, or we generate data to serve that particular sort of function that are part of the value chain that we're in. But I have yet to find someone who is willing to say, I will invest my time, money, and effort to create data for them, right? Unless I'm getting paid for it or something like that, right? So that's a little bit of the challenge. And in particular, I would argue that the challenge is a system challenge that we have in the US, which is there aren't that many organizations, because of the way the healthcare delivery system is structured. We might ask the question, who has your long-term health interest as a key part of what they want to provide to you, Chris? I mean, is it your doctor? I mean, in theory they do, but you could change your health insurance next year and you may find that doctor is now out of network. And so now you've either got to pay more out of pocket, or more often what happens is you change doctors, right? And the same thing with a health insurer, right? Where they may have your interest in mind, but in the US, people change their health insurance, every 2 to 3 years? And so you've got that churn, right? Where you don't have the organization that says, I've got Chris for 40 years. And now I'm going to think really hard about what are the kind of investments we want to make working with Chris on investing in his 40-year horizon, which would then give me the incentives to say, I need to get all the data I can on Chris, create that longitudinal patient record, think about wellness, as well as health, acute health, right? So your sickness and your wellness, and presumably focus more on your wellness so that you aren't sick, as often. And then the data would start aligning with that. And we think about value-based care having that set of incentives, right? And I think that we've seen in lots of places where organizations that do take on the value-based care, sort of contract, they do end up making those kinds of investments in more enriched and more interoperable data. But the problem is that value-based care hasn't had the kind of traction in the market yet that we wanted it to be able to have. It's getting there, but but I think it may be that we need other sorts of drivers to get us there more. Now, what we focus on at ONC is to say, well, how do you reduce the barriers, right? I mean, one way is to say, well, I need to create strong incentives. That certainly is a part of it. But the other is, if I can just make it easier, maybe that'll make more data flow as well, right? Because it's like, well, I'm not going to collect data for your purpose, but if it's really easy for me to share the data and there's no prohibitions on my doing it, well then fine, I'll do it. So that's what we do, is we say, let's have open industry standards, and then we also have policies in place that literally say the information blocking rules that came out of the 21st Century Cures Act that literally say to providers and technology vendors, you're not allowed to hoard data. And so, it's both the coupling of that policy as well as trying to, make it easier to share information that I think is a key part of it.
Well, I like that perspective, because a lot of our conversations have been around incentives, but on the other end, if you are lowering the barrier to entry, lowering the cost, then the incentive amount needed becomes
lower.
Yeah, let's get it down to sure, why not?
Yeah, right.
So that leads me to another question is, so let's say that we accomplish like a good chunk of interoperability. What are some of the use cases that you see blossoming from this more idealized like connection between these health systems?
Sure. Well, I mean, I think there's a wide variety of them. I mean, the most immediate one that we always focus on is just that treatment use case. So getting to the question that, or the, sort of the story that you had talked about at the beginning of the person having the wrong kidney removed, for example. And who knows what the story was behind that.
Yeah.
Right? But in general, you want to be able to say that at least for treatment, if we just focus on that for a second, that there's no reason that wherever you show up for care, that information isn't already available to the provider. So you're not wondering why does this doctor not know why I'm here? Why does the cardiologist not know why the PCP sent me here? And more important, why are they relying on me for answers to these questions? Like, what meds am I on? I could forget, right? I'm not the best reporter of my medical record information. And why wasn't it there at a time so that they actually could have thought about it in advance before I got there? Right? Which I know most providers would like to be able to do. It's like, I don't want to be thinking about this on the fly. I'd love to know that the records are there. Day before, I'm going to look at Chris's record, give a little bit of thought to what I'm going to do in that, in that exam, and then be able to do that. So that's one level. Is just saying, we should be able to take that off the table. Mm-hmm. So your information is where it needs to be in the healthcare space. I think as we start to expand that, then, which is the next set of things we want to be able to accomplish, is how do we get that integrated with your payers, your health insurers? I mean, every one of us has had the experience, and I know I'm going through this right now with my own care. Is you're like getting bills from all over the place, and you're just like, what? How does this work? Like, do I have to call every my insurance company and like figure out, well, how come this isn't paid for? How come that isn't paid for? How come that isn't paid for? Sometimes it's just, oh, well, they didn't get the right documentation. I needed prior auth, and I didn't know I needed prior auth, so now I'm sitting and waiting. I show up at the pharmacy, and I didn't get, the medication because they say, oh, you need prior auth. No one seems to know what the prior auth is. All of those things. That's kind of a next level of things that we're working very hard with CMS to accomplish, because at the end of the day, those are things that people notice right away. And they may forgive the healthcare delivery system if your doctor doesn't have all the medical record information, because I think it's, the experience of most people, I think, is kind of like congressmen. You may hate the Congress, but you really like your congressman, mm-hmm. right? That's kind of true across the board. And like with doctors too, it's like, I hate doctors. My doctor, I really love my doctor, love my hospital. But hospitals in general, no. Doctors in general, no. So, and so they may be more forgiving on that. But where it really bites them are things like this insurance stuff, and increasingly the cost stuff, which is more and more of the cost is being placed on the patient to have to pay out of pocket. And so we need to be thinking more about interoperability as being, how do we solve those immediate patient needs? Right now, we don't even think about interoperability as saying, I need to provide the cost data to the provider so that when the provider says, I think you should have this MRI, and the patient says, well, how much is that going to cost? And right now, most providers will be like, I have no idea. Go to the front desk, maybe they can help mm-hmm. you, maybe not, I have no idea. But increasingly, that interoperability is really important, I think, for that relationship with the patient, but also to help the patient make the appropriate decision. Because if they can't afford it, if they don't know what they're getting into, then we're in a worse situation, because you actually don't know what the patient's going to do. You say, well, I ordered an MRI, they left. Outside of this conversation, they decided, I'm not going to get it because I can't afford it. Now you have no idea what happened. Right? There could be a huge amount of risk now out there. The patient really should have gotten the MRI, and now 3 years later they show up with cancer that could have been prevented. Right? So I think we need to be thinking more broadly in terms of things that directly affect patients' lives in ways that aren't as medical as we might think that they are.
Yeah, I like that perspective. Honestly, I asked that selfishly. I was really looking to know, and
sort of but the financial toxicity is kind of the term that that people have been sort of throwing around for that.
Yeah,
which I think is a real important part of it.
And by that financial toxicity, it's kind of is it that there's an overemphasis on billable events, and once that's happened, you lose perspective on?
Yeah, I think that's a part of it, and that it's and that we have mechanisms, payment mechanisms, and other mechanisms that in many ways are very hostile to what patients really want and deserve, I would argue, at the end of the day. It's a whole system that's designed not with the patient in mind, not with the idea of saying we want to improve access first and foremost for patients so that isn't a barrier to them, and we want to make it as easy as possible. I mean, you think about what Amazon does, right? I mean, Amazon every single day thinks about how do I make it as easy as possible for this person to pay for something. And in some ways that has a downside. They're buying too much on it, right? But they're saying, how do I make this as easy as possible? As a healthcare system, I would argue we really don't think about that at all on the financial side. We don't think about how do I make healthcare payment as easy as possible so that can get out of the way and patients can just get the care they need.
Well, Micky, I want to say this. There's something that we ask each of our guests, which is if you had a magic wand and you could change any one thing about the healthcare system, what would it be? Our previous guest, he just said, in so many words, interoperability. I wonder if we were to give you that same superpower and change anything about healthcare, what would that be?
It would be it's going to be general and not so specific, but somewhat specific in a certain way, which is whatever it is, whatever type of system that we can get in place that has the incentive to think about an individual over their entire life. It was what I was alluding to before. Right now, there is nothing. Our employment, the way we do insurance tied to employment, the fact that you've got tremendous amount of churn in insurance, the fact that you switch providers all the time because that's tied to your insurance. No one has an interest in your long-term benefit at the end of the day. And I think that if I could wave my magic wand, and I'm sort of agnostic to, is it a completely private sector approach, or is it a single payer system, or there's a variety of models to sort of do that. And I'm a little bit agnostic to how that gets done, but I think that that's what I would do, is say we need some kind of economic structure that gives an incentive to organizations to invest in individuals over the course of their entire life.
Is someone thinking about it?
I think a lot of people, certainly the conversation about health insurance and all the conversation that came up in the election about, Medicare for all or a single payer system. I think underlying that is kind of that idea. Part of it, it's always framed as an argument about efficiency of, we have so much inefficiency. But I think a part of that discussion is also about the fact that with that much churn, we don't have an end-to-end, sort of visibility into something that would improve patients' lives, but would also cost us as a society less money than we spend today, right? We spend more money by far per person on healthcare than any other country on earth, and our healthcare status is definitely not the best in the world. It is middle of the road by by very generous measures.
Well, I think it's a massive thought, but it's so pragmatic, and I do think that even though you don't have the magic wand, it is something that if we coordinate properly can happen. For the people that want to see the path to that journey and see what you're sharing and what your updates are and things like that, what's the best way to keep in touch with you or follow you?
Sure. So you can certainly follow me on Twitter at Micky Tripathi 1. There's some other Micky Tripathi out there. I don't know who it is. So I'm at
no
at
fake
Tripathi
Tripathis out here. Reveal yourself.
Right. And so that would certainly be one way. The ONC, the Office of National Coordinator, also is on Twitter. We're on LinkedIn. And then finally, you can subscribe to our email blast and just be on our subscriber list, and you'll have emails pushed to you that give updates. We have a blog that we publish on every single week at a minimum. So we try to do everything we can to be as forward-leaning into communication as possible.
Well, absolutely thankful. Love the transparency, love the stories and examples, and we hope to get you for a longer conversation at some point in the future.
Great. Love to. Thanks,
thank
Chris.
you.
Okay. Take care.